Okay, it's time to talk about anemias. I'm just going to be reading a case, so about 50 pages, beginning with the presentation of the case. Then we're going to go through some of the basics, and then we'll talk about some of the anemias. So if you're interested, read along. This is Med School Radio. Anemias, case presentation. A 56-year-old woman has experienced increased fatigue over the past 9 months. Her physical examination is unremarkable. She is not a vegetarian. Laboratory studies show a hemoglobin of 91.6 grams per deciliter, a hematocrit of 29.2%, MCV of 124 micrometers cubed, a platelet count of 265,000, and WBC count of 8350 millimeters cubed. The reticulocyte count is low. Hypersegmented neutrophils are noted on the peripheral blood smear, and antibodies to gastric hydrogen potassium ATPase are found. What is the diagnosis and how should she be treated? So we're going to go through some of the basics first, and then later we will end up with some discussion of the case. So first, introduction to red blood cells. Red blood cells, or erythrocytes, are adapted for one preeminent function, and that is to carry oxygen bound to hemoglobin to the trillions of cells of the body. This will provide the final electron acceptor at the end of the electron transport chain, without which aerobic metabolism cannot proceed. In fact, with 95% of the intracellular protein content of the red cell comprised of hemoglobin, not only does hemoglobin define the function of the red cell, but it also helps determine the structure of the red blood cell. This is most dramatically illustrated in the abnormal forms found in sickle cell anemia, which is discussed later. On a Wright's stain smear and with a scanning electron microscope, the mature erythrocyte, which is devoid of all organelles, resembles a donut with the center of the cell greatly compressed. This biconcave disc shape provides maximal surface area for efficient oxygen transfer. This shape also provides great flexibility for the red cell to pass through the thousands of miles of capillaries with an internal diameter of 2 to 3 micrometers, which is considerably less than the red cell diameter of 8 micrometers. For the red cell to withstand the shear forces on such a voyage, it must be able to conform to the diameter of the capillary and resume its biconcave shape upon exiting. Deformability arises from the red cell membrane structure and associated cytoskeleton, comprising an interlocking network of several proteins including spectrin, ankyrin, band 3 complex, and actin. In a sense, the cytoskeletal proteins bind spectrin to the inner membrane surface in a manner reminiscent of how a suspension bridge roadway is bound to the main suspending cables of the bridge. Anemia is a broad diagnostic term that refers to a clinically significant reduction in the mass of circulating erythrocytes. It follows that since the overriding role of the red cells is to carry oxygen, in anemia, the oxygen carrying capacity of the blood is decreased. In this discussion, we will consider the myriad causes and of pathology of the red blood cell, but note here that acute or chronic blood cell loss can result in anemia. Other general classes of defects causing anemia include diminished erythropoiesis and increased destruction, or hemolytic anemias. We will begin our discussion by briefly considering the origin and development of the erythrocytes and other formed elements of the blood. Erythropoiesis. Although some precursor myeloid cells are found in the yolk sac during the 3rd week of life, by the 3rd month the liver is the main site of blood cell development, hematopoiesis in utero. Hematopoiesis can be demonstrated in bone marrow by 4 months in utero, and by birth the bone marrow has become the sole hematopoietic site in the body. Until puberty, marrow throughout the skeleton is capable of generating blood cells, but at 18 years of age, hematopoiesis is confined to limited sites, including the vertebrae, ribs, sternum, skull, and pelvis. It should not be surprising that that red cells, granulocytes, monocytes, platelets, and lymphocytes all arise from a pluripotential stem cell. This pluripotential cell is the ancestor of the two lines of multipotent progenitors, the common myeloid and common lymphoid stem cells. The common myeloid stem cell gives rise to the following three classes of committed cells: erythroid, megakaryocytic and eosinophilic, and granulocyte macrophage pathways. Differentiation is the emergence of different biochemical and structural properties in cells that were initially equivalent. Hematopoiesis entails the selective expression of information contained in the genome of a cell line to produce a distinctive cell type. Recall that diploid cells have the same genetic complement, and cells of different organs repress some genetic information and express other genetic information to follow a path to their ultimate mature phenotype. Hematopoietic stem cells, or HSCs, are characterized by the ability to self-renew and differentiate into all mature blood cell lines. HSCs are rare, occurring at a frequency of 1 HSC per 10,000 to 100,000 bone marrow cells. Using monoclonal antibodies and flow cytometry, the various cells in a developmental sequence have been characterized by their expression, or lack thereof, of specific surface markers, clusters of differentiation, also known as CD. The growth, proliferation, differentiation, and suppression of apoptosis of hematopoietic precursor cells are governed by growth factors or cytokines, which are all signal molecules. For the erythrocyte, the most important signal molecule is erythropoietin, which acts to prevent apoptosis. The least mature erythrocyte precursor is known as the pro-erythroblast. As the cells proceed towards the mature erythrocyte, the deep blue color from high RNA content of immature cells is supplanted by the red color of hemoglobin. Once the nucleus of the cell is extruded, the cell is known as the reticulocyte. These cells are larger than mature red cells, contain remnants of ribosomal RNA and mitochondria, and differ in shape from red blood cells on scanning EM. Once released into the bloodstream, reticulocyte maturation continues for another day or so using the supravital stains, new methylene blue or brilliant crescent blue. The reticulocytes are identified by the presence of punctuate purplish blue inclusions. Normally, reticulocytes represent 0.5 to 2% of peripheral red cells. The ability to mount a brisk reticulocytosis to a condition causing anemia, for example blood loss or hemolysis, reflects a bone marrow capable of responding to the insult. In contrast, aplastic anemia associated with a drastic decrease in HSCs, the reticulocyte response is feeble. Now we will start to talk about the anemias, and we're going to talk about anemias of blood loss. Hemorrhage from trauma produces signs and symptoms of hypovolemia and hypoxia, with weakness, lightheadedness, confusion, pallor, and sweating. Depending on the degree of compensation, blood pressure may be normal or decreased and is usually associated with significant tachycardia. If the patient can tolerate being moved from the supine to the sitting position, an increase in pulse by greater than 25% or a fall in systolic blood pressure of greater than 20 milligrams mmHg reflects a blood loss of greater than 1 liter. Because red cell mass and plasma volume are lost in parallel in acute hemorrhage, the hemoglobin or hematocrit will, before compensation, be found in the pre-morbid range. Emergency therapy includes controlling the loss of blood and providing IV fluids, preferably packed red cells, to maintain volume and oxygen carrying capacity. Patients suffering from chronic blood loss usually have occult lesions, tumors or ulcers of the gastrointestinal tract, or overt or occult lesions of the uterus. In an adult male or postmenopausal woman, testing a stool for occult blood is mandatory to identify a potential gastrointestinal lesion. From a hematopoietic point of view, chronic blood loss is a cause of iron deficiency anemia, which is discussed below. Now we will move on to talk about anemias of diminished erythropoiesis. If critical vitamins, B12 or folate, or elements such as iron are deficient in the diet, red cell formation will be disrupted. In the case of vitamin B12 and folate, DNA synthesis is impaired and cells are unable to divide, instead becoming megaloblasts. In the case of iron deficiency, the most common nutritional deficiency worldwide, heme synthesis is impaired because iron must be inserted enzymatically into the porphyrin ring. I'm going to read that again. If critical vitamins B12 or folate or elements iron are deficient in the diet, red cell formation will be disrupted. In the case of vitamin B12 and folate, DNA synthesis is impaired and cells are unable to divide, instead becoming megaloblasts. In the case of iron deficiency, the most common nutritional deficiency worldwide, heme synthesis is impaired because iron must be inserted enzymatically into the porphyrin ring. Other causes of decreased erythropoiesis include anemia of chronic disease and aplastic anemia. What is the role of iron in life? Iron is an essential metal for a number of enzymes involved in oxidation reduction reactions, including cytochromes, peroxidases, catalases, and ribonucleotide reductases, and as a carrier of oxygen in hemoglobin and myoglobin. Iron is vital to the life of cells and the organism because it is able to undergo a reversible one-electron oxidation reduction reaction that interconverts ferrous to ferric iron, the two main oxidation states of iron. However, there is a downside to this chemical process. The same oxidation reduction reaction participates in the Fenton reaction, in which ferrous iron, FeLl, reacting with hydrogen peroxide produced in cells, forms the hydroxy radical OH, the most powerful of the reactive oxygen species. The hydroxy radical superoxide anion cause peroxidase damage to membrane lipids, proteins, and nucleic acids. As a consequence of the dangerous reactivity of iron, almost all iron within cells and in the body is bound to covalently or non-covalently to a protein to control and restrain its activity. This accounts for the fact that heme-containing proteins, hemoglobin, cytochromes, catalase, and peroxidase, and non-heme forms, ribonucleotide reductase, iron-sulfur proteins, and metalloflavoproteins, are the main iron species in living organisms. The list of reactions in which these iron-containing proteins are involved, including oxygen transport, electron transport, oxygenations, and hydroxylations, reveals why they play such a central role in life. When not involved in oxygen transport or in an enzymatic role, iron is bound to storage proteins, ferritin and hemosiderin, or is transported in the blood bound to transferrin. Read the last sentence again. When not involved in oxygen transport or in an enzymatic role, iron is bound to storage proteins such as ferritin and hemosiderin, or is transported to the blood bound to transferrin. Okay. So hemosiderin and ferritin are storage proteins, and it's transported in the blood with transferrin. In sum, free iron is dangerous to cells because of its propensity to form toxic free radicals, thus accounting for incorporation into proteins to control its reactivity. Noting the presence of rust on bridges and on automobiles confirms how eagerly oxygen and iron react together. Let's continue and talk some more about the distribution of iron. Adult men normally contain 35 to 45 milligrams of iron per kilogram of body weight, while menstruating women have smaller iron stores because of periodic blood loss. Approximately 1,800 milligrams of iron is contained in the circulating red cells mass, 600 milligrams in the reticuloendothelial macrophages, 1,000 milligrams in the liver, and 300 milligrams in muscle as myoglobin. Iron circulating in the blood bound to transferrin accounts for only 3 milligrams. And dietary absorption brings in 1 to 2 milligrams of iron daily, which offsets the loss of iron from sloughed mucosal cells of the GI tract and menstruation in women, accounting 1 to 2 milligrams of iron per day. It is important to note that there is no organ charged with ridding the body of iron. Thus it is the macrophage-bound iron that supplies 20 to 25 milligrams of iron per day necessary for the bone marrow to produce approximately 250 million red cells per day. Macrophages obtain iron by phagocytizing F8 red cells and retaining the iron to be used repeatedly to provide this metal for heme synthesis. Transferrin can bind 2 iron atoms per molecule. Normally, serum transferrin is approximately 1/3 saturated with iron, and this iron is delivered to developing bone marrow erythroid precursors called normoblasts. When after approximately 120 days these erythrocytes become senescent and are removed by the monocyte macrophage system, the iron released from the hemoglobin catabolism is again bound to transferrin, which delivers iron to the bone marrow for another round of red cell synthesis. Absorption of dietary iron from the intestine. Most iron absorption occurs in the first segment of the duodenum. Heme iron found in meat is more efficiently absorbed than non-heme iron, although the mechanism of heme iron is not well understood. In contrast, progress has been made in elucidating non-heme iron absorption. Eating habits are changing, with meat ingestion decreasing because of cardiovascular and colon cancer risks. Consequently, non-heme iron found in egg yolks, vegetables, lentils, spinach, and lima beans, and nuts is assuming a greater importance in providing iron in the diet. Gastric acid helps solubilize dietary iron and also promotes conversion from ferric iron to ferrous iron, the common form most readily absorbed. The decline in gastric acid production with aging can reduce iron absorption in the elderly, but proton pump inhibitors do not appear to affect iron absorption. Vitamin C increases non-heme iron absorption, as does meat, while fiber and phytate decrease iron absorption. As noted, most non-heme iron is in the ferric form. A cytochrome B-like ferrireductase CDYYTB can catalyze reduction of Fe3 to Fe2 iron. The Fe2 iron is then transported across the apical luminal membrane by divalent metal transporter 1, or DMT1. As the name suggests, DMT1 also transports the divalent forms of manganese, copper, zinc, and lead. Once inside the enterocyte, a small fraction of the iron is incorporated into ferritin, an iron storage protein. But the bulk of the iron is absorbed into the blood at the basolateral surface by another iron transporter called ferroportin. In 2001, a 25 amino acid peptide named hepcidin was shown to regulate basolateral uptake of iron by binding to ferroportin, triggering degradation of ferroportin within lysosomes. Subsequently, it was shown that hepcidin controls release of iron from macrophages. Transferrin is the protein of the bloodstream responsible for transporting iron in the ferric state to the erythroid processors, lymphoid cells, and tumor cells, thus preventing it from exerting the peroxidative toxic actions derived earlier. Uptake by cells is via a transferrin plasma membrane receptor, or TFR, that is internalized by receptor-mediated endocytosis. It has been shown that erythroid precursors, with their enormous demand for iron, express up to 800,000 TFR molecules per cell when they are synthesizing hemoglobin. Normally, transferrin is approximately 1/3 saturated with iron, but as iron deficiency grows worse, the percent saturation declines, and serum TF saturation is the ratio of serum iron to total iron binding capacity. If saturation is an index of how much iron is available for red cell production. IF saturation is an index of how much iron is available for red cell production. Another iron storage protein, ferritin, is found in the cytoplasm of cells and can hold up to 4,500 atoms of iron. A small amount of intracellular ferritin leaks out into the bloodstream from macrophages and hepatocytes. A low serum ferritin is a useful, non-invasive indicator of diminished iron stores. Now let's talk about hepcidin and whole body iron homeostasis. The main regulator of iron absorption from the duodenum and macrophage release. Let's start again there, I got confused. Another iron storage protein, ferritin, is found in the cytoplasm of cells and can hold up to 4,500 atoms of iron. A small amount of intracellular ferritin leaks out of the bloodstream from macrophages and hepatocytes. A low serum ferritin is a useful, non-invasive indicator of diminished iron stores. Hepcidin and whole body iron hemostasis. The main regulator of iron absorption from the duodenum and macrophage release for erythropoiesis is the protein hepcidin. This 25 amino acid peptide is synthesized by hepatocytes and decreases iron absorption when stores are inadequate. Hepcidin acts by binding to ferroportin, causing a conformational change that leads to internalization into the cell and degradation into lysosomes. In this manner, hepcidin prevents further iron absorption in response to iron overload or inflammation. It follows that hepcidin synthesis is diminished in iron deficiency, ineffective erythropoiesis, and hypoxia. Notably, hepcidin also binds to a macrophage, ferroportin, preventing iron efflux. In this action, hepcidin is believed to deny iron to microorganisms that depend on iron for many metabolic activities. Finally, hepcidin blocks export of iron from hepatocytes by the same ferroportin-based inhibition. It is interesting that hepcidin bears structural similarity to antimicrobial peptides such as defensins. Hepcidin production is upregulated in inflammation, chronic disease, through the action of cytokine interleukin-6, which includes hepcidin transcription through stimulation of the JAK-STAT3 phosphorylation signaling cascade. Thus, when increased erythropoiesis is needed, blocking synthesis of hepcidin increases the availability of iron by intestinal absorption and macrophage iron efflux. In contrast, in inflammation and chronic disease, hepcidin mRNA transcription is upregulated, thus causing iron to be sequestered and denying this vital element to invading microbes. Now let's move on to discuss iron deficiency anemia. Because absorption of iron is not very efficient, and because there is no physiologic mechanism for iron excretion, Iron hemostasis is centered on regulating absorption. Earlier we learned that serum ferritin is derived from the storage pool of body iron and offers a rough correlation with the state of body iron stores. For example, in iron deficiency anemia or IDA, serum ferritin is less than 12 micrograms per liter, while in iron overload values it is greater than 4,000 micrograms per liter, which has been recorded. We also saw that transferrin is normally 1/3 saturated with iron, with a total iron binding capacity of TIBC of greater than 300 micrograms per deciliter. We also reviewed the role of DMT1 in the absorption of non-heme iron and the role of hepcidin in inhibiting iron uptake by its effect on the availability of iron efflux protein ferroportin. IDA is the most common nutritional anemia worldwide. Chronic blood loss without sufficient replacement is the most frequent etiology of iron deficiency anemia. In the industrialized world, this translates to the loss of blood through the GI tract from a tumor or other pathologic condition, such as ulcer, hookworm in the southern US, and salicylate use. In men and postmenopausal women and in menstruating women from excessive loss associated with their cycles. In the developing world, parasite infestation, which may affect as many as 3 billion individuals, is the main cause of this slow loss of blood. Dietary lack is unusual except in milk-fed infants who receive no iron supplementation. During periods of growth, children need extra iron, as do pregnant women to accommodate the needs of the fetus. Impaired absorption is unusual, but can occur in malabsorption syndromes associated with steatorrhea and decreased gastric acidity. Clinical and laboratory manifestations of iron deficiency anemia or IDA. IDA is associated with fatigue that stems from decreasing oxygen carrying capacity and diminished activity of iron-containing enzymes and components of the electron transport chain. Transfusion with red cells does not usually correct the fatigue, which requires repletion of iron to restore the activity of affected enzymes and heme-containing proteins. Rare physical findings include sore tongue, also known as glossitis, and angular stomatitis. Bright fingernails, brittle fingernails, and spooning of the nails, koilonchias, are sometimes seen. An unusual craving for ice or clay, termed pica, is often associated with IDA. The CBC will reveal decreased MCV, hemoglobin, and hematocrit in advanced anemia. The serum iron is low and is associated with an elevated transferrin level, causing transferrin saturation to be less than 10 to 15%, because normal is 30%. And serum ferritin levels, a surrogate for tissue iron stores, is less than 12 micrograms per liter. And because there is not sufficient iron to create heme protoporphyrin, free erythrocyte protoporphyrin levels are elevated. One more time. Serum ferritin levels, which is a surrogate for tissue iron stores, is less than 12 micrograms per liter. And because there is not sufficient iron to create heme protoporphyrin, free erythrocyte protoporphyrin levels are elevated. Treatment. Replacement of iron with ferrous sulfate or liquid preparations which are better tolerated, and definitive therapy for the underlying cause of the iron loss should be undertaken. Symptoms of fatigue improve within 1 week and reticulocytosis becomes brisk by 7 to 10 days, but the hemoglobin level does not rise until approximately 2.5 weeks. Treatment for approximately 2 months is necessary to restore a normal hemoglobin level. Repeat serum ferritin should disclose when iron stores have been repleted. Next, we will discuss anemia of chronic disease and inflammation. Most authorities consider anemia of chronic disease, or ACD, the most common cause of anemia after iron deficiency. ACD is common among hospitalized patients and has been shown to arise from the actions of elevated levels of inflammatory cytokines. Hepcidin production is increased by interleukin-6, tissue necrosis factor alpha, and possibly lipopolysaccharides. The result is that its inhibitory action on ferroportin, hepcidin prevents iron release from the reticuloendothelial macrophage system and inhibits iron absorption from the duodenum. These actions deny microbes and tumor cells access to iron at the expense of mild to moderate anemia. Another action of hepcidin is the inhibition of erythropoietin (EPO) release of interleukin-1 and tissue necrosis factor alpha by the kidneys. Further, TNF-alpha and interferon gamma and interleukin-1 inhibit proliferation of erythroid cells together by suppressing the response of EPO. Finally, this mix of cytokines increases erythrophagocytosis by macrophages of the RAS. The clinical manifestations of ACD or anemia of chronic disease, usually reflect the underlying disease rather than the anemia. Hemoglobin levels are usually in the 8 to 10 grams per deciliter range. The diagnosis rests on low serum iron in the face of normal or increased total body iron stores. Serum ferritin, as a gauge of iron stores, is usually normal or elevated in ACD, as opposed to IDA, in which levels are significantly decreased. Serum transferrin receptor, STFR, is a fragment of the transferrin membrane receptor that is increased in iron deficiency, but is usually normal in ACD, reflecting adequate iron within erythroid cells. Now for treatment. Treatment is a controversial area in which some authors suggest it is better not to treat mild to moderate ACD, or anemia of chronic disease. All agree that treating the underlying disease is essential, and that providing iron to iron replete individuals is useless and potentially harmful. The patient is generously supplied with iron, which is not available due to sequestration in macrophages. We will now discuss megaloblastic anemia. The hematopoietic system is charged with continually replenishing red cells, leukocytes, and platelets in the bloodstream. As a consequence, cell division occurs continuously, pouring out many millions of cells of each lineage per day. The key event in cell division is DNA replication, occurring in the S phase of the cycle, so that the cells that undergo mitosis will distribute identical copies of the DNA to each daughter cell. The hallmark of impaired cell DNA synthesis in the hematopoietic system is a megaloblastic anemia, characterized by abnormally large precursors or cells which are blasts that populate the bone marrow. All cell lines, including erythroid, myeloid, and megakaryocytic cells, are affected in megaloblastic anemia, but most interest has been focused on the erythroid cells. Greater than 95% of cases of megaloblastic anemia are caused by a deficiency of folic acid and vitamin B12 or cobalamin, the two water-soluble vitamins required for production of deoxyribonucleotides, the building blocks of DNA. The megaloblast is a red cell precursor in which DNA synthesis is impaired. While RNA and protein synthesis proceed normally, this results in a large cell because it undergoes fewer cell divisions than does the normalized cell precursor. Anemia is a consequence of ineffective erythropoiesis, the premature destruction of defective erythrocyte precursors in the bone marrow because of DNA of these precursors is damaged. Folate and cobalamin participate in reactions essential for purine and pyrimidine biosynthesis. These two vitamins interconnect biochemically in the formation of DTMP and in the methionine synthase reaction. Now let's talk about cobalamin. Cobalamin, or vitamin B12, is a red, water-soluble vitamin with a structure resembling the heme molecule and is therefore a porphyrin derivative with cobalt instead of iron in the center. The ring is referred to as a Corin ring. Daily requirements are 2.5 to 3.0 micrograms per day. And because cobalamins are only produced by microorganisms, ingestion of meat, fish, and egg yolks are the principal dietary resources. This limited array of foods puts vegetarians at risk for developing B12 deficiency. Thus, they should take oral vitamin B12 supplements because the liver stores 2 to 5 grams of B12. Vitamin B12 deficiency can take years to develop. Because neurologic and hematologic abnormalities are a feature of B12 deficiency, it is particularly important that B12 deficiency be recognized and treated. Cobalamin absorption and transport. In the presence of adequate gastric acid, cobalamin, or CBL, in food is released by proteolysis and binds to a high-affinity cobalamin binding protein called R-binder. The CBL-R binder complex is digested in the duodenum, releasing the CBL, which then binds to intrinsic factor, a glycoprotein produced by the parietal cells of the stomach. These are the same cells that secrete HCl for digestion. When CBL, or cobalamin, binds to intrinsic factor, the complex is rendered resistant to digestion and travels to the distal ileum, where the complex binds to a specific receptor. Once taken up by the ileal mucosal cell, cobalamin is transferred to transcobalamin 2, which is secreted into the bloodstream, serving as the carrier for tissues that need B12, including bone marrow, liver, gastrointestinal mucosa, and other dividing cells, for example, germ cells. In pernicious anemia, autoimmune destruction of the gastric parietal cells causes loss of intrinsic factor production and consequent cobalamin deficiency. Biochemical role of cobalamin. Cobalamin is an essential cofactor for two mammalian enzymes, methylmalonyl coenzyme A mutase and methionine synthase. Firstly, methylmalonyl CoA mutase is a mitochondrial enzyme that uses deoxyl adenylcobalamin as the coenzyme form and catalyzes the conversion of methylmalonyl-CoA to succinyl-CoA, a citric acid cycle intermediate. From a chemical point of view, this is a complicated reaction in which the coenzyme stabilizes a free radical formed during the course of the reaction. No other coenzyme can substitute for deoxyadenylcobalamin. Methionine synthase is a cytosolic enzyme that uses methylcobalamin as a coenzyme and catalyzes the transfer of a methyl group from methylcobalamin to homocysteine to form methionine. It is in this reaction that cobalamin and folate interconnect because the methyl group of 5-methyl tetrahydrofolate, or METHF, regenerates methylcobalamin and also yields the THF needed for 1-carbon metabolism. This is a complex reaction in which methylcobalamin accepts methyl groups from 5-methyl-THF and donates the methyl groups to homocysteine. During the reaction, B12 cycles between methylcobalamin and free cobalamin and is demethylated by homocysteine. Then remethylated by METHF. The methionine formed in the methionine synthase reaction can be adenylated by ATP to form S-adenosylmethionine, or SAM, a high-energy compound that donates methyl groups to various proteins, for example, myelin-basic protein, neurotransmitters, phospholipids, RNA, and DNA. So it donates methyl groups to various proteins, neurotransmitters, phospholipids, DNA, and RNA. When these two cobalamin-requiring reactions are defective because of CBL deficiency or from an inborn error, methylmalonic acid and homocysteine will accumulate in the blood. Measurement of these compounds can help establish the presence of CBL deficiency as the cause of megaloblastic anemia. Causes of cobalamin deficiency. Vegetarians and individuals who consume little or no meat because of poverty constitute the largest group of individuals with CBL deficiency worldwide. Diminished gastric acid secretion, especially in the elderly, can be a major factor contributing to the inability to liberate CBL from its covalent bond to protein. This category includes atrophic gastritis and individuals taking proton pump inhibitors and H2 blockers. Deficiency of intrinsic factor is found in pernicious anemia, an autoimmune disorder characterized by destruction and atrophy of gastric parietal mucosa, which leads to severe cobalamin deficiency. Approximately 10% of patients with pernicious anemia have antibodies to intrinsic factor in the serum, and a much larger percentage have these antibodies in the gastric mucosa. Let's talk about folates. Folates are widely available in the diet, being found in green leafy vegetables, asparagus, broccoli, spinach, and lettuce, lima beans and fruits, lemons, bananas, and melons. Most individuals require 400 micrograms per day, but pregnant women before conception need at least 600 micrograms per day. Prolonged cooking can destroy greater than 50% of dietary folate. Alcoholics frequently do not have a balanced diet, which is the leading cause of folate deficiency. What is the biochemical role of folate? Folate coenzyme species donate one carbon groups in various oxidation states in construction of the purine ring that culminates in the formation of AMP and GMP. Folate is also key to the conversion of DUMP and DTMP, a reaction that involves the methylation of deoxyuridylate to thymidylate. The coenzyme formed for this reaction is N5N10-methylene THF, which furnishes the methyl group in a reaction catalyzed by thymidylate synthase. Failure to convert DUMP to DTMP leads to miscorporation of DUMP into DNA instead of the correct DTTP. Recall, thymine occurs in DNA and uracil in RNA. DNA uracil glycosylase recognizes the error, but there is not sufficient DTTP to repair the error, and this causes DNA fragmentation and cell death. Methyl THF transfers a methyl group to homocysteine, converting homocysteine to methionine. This reaction requires B12 because the chemistry involved needs special reactivity only cobalamin can provide. Without methylcobalamin, the reaction is blocked by 5-methyl-THF. Already, the major intracellular form of folate accumulates further. This is because 5-methyl-THF is a dead-end metabolite because it cannot be reoxidized. As a result, folate will eventually be sequestered as 5-methyl-ITHF. No THF will be available for purine synthesis or conversion of DUMP to DTMP, and the cells will perish. This phenomenon is known as the folate trap hypothesis. Next, we will discuss clinical manifestations of megaloblastic anemia. For many individuals, noting an increased MCV on a routine CBC may be the first clue to the presence of megaloblastic anemia. If the anemia has been present for several months, pancytopenia will be present, as will GI findings because of mucosal injury from depressed DNA synthesis. If there is evidence of dorsal spinal column involvement with paresthesias, B12 deficiency must be ruled out. If subacute combined degeneration is not promptly treated, spastic ataxia may ensue from demyelation of the dorsal and lateral corticospinal columns of the cord, associated with the positive Babinski sign. A clue is loss of position sense in the toe next to the big toe. These findings account for the name combined systems disease. Now the diagnosis. Once it has been established that a megaloblastic anemia is present with an MCV of greater than 110 FL, it is essential to determine if the cause is folate, cobalamin, or combined folate and cobalamin deficiencies. Thus, it is necessary to establish whether or not there is a nutritional deficiency or underlying disease, including pernicious anemia or a fish tapeworm, which steals cobalamin. Regarding folate, dietary deficiency is the most common cause, but trimethoprim and pyrimethamine inhibit the dihydrofolate reductase needed to restore the active THF forms of folate. Sulfasalazine decreases the breakdown of dietary folate polyglutamates to monoglutamates, thereby hampering absorption. Food faddism and a strict vegetation diet are important points to cover in the medical history. Laboratory tests. A MCV of greater than 110 FL with macroovulocytes on peripheral smear and a low reticulocyte count suggests a megaloblastic anemia. Evidence of intramedullary hemolysis because of ineffective erythropoiesis includes increased serum LDH and bilirubin. Hypersegmented nuclei of neutrophils are seen in megaloblastic anemia, but tend to be a late sign. Measuring cobalamin and folate levels are necessary, but should be supplemented with measurement of serum homocysteine and methylmalonic acid levels to confirm the diagnosis of cobalamin deficiency. If homocysteine is elevated but methylmalonic acid is normal, this suggests a folate deficiency. A bone marrow examination is rarely needed. Why does demyelination occur in cobalamin deficiency? For many years it has been proposed that the cause of B12 deficient myelopathy is the abnormal methionine synthase reaction in which cobalamin and folate function together, with the result that methionine synthesis is greatly impaired and homocysteine accumulates. Normally, methionine is converted to SAM, a powerful methyl group donor that is used to methylate myelin, basic protein, and myelin lipids. The result is an unstable myelin sheath. The new neuroimmunologic theory, based on the role of vitamin B12 in the regulation of cytokines and growth factors, has gained traction as an additional contributor to the myelopathy. This theory proposes that B12 deficiency is associated with increase in TNF-alpha and CD40L, which have been shown to exert myelin-toxic effects in animal models. This work, in conjunction with the role of deficiency of SAM, gives a more complete picture of the factors causing myelin damage, but does not explain why damage is largely confined to the posterior columns and the corticospinal tracts. So how does folate deficiency in the periconceptional and early fetal period cause neuronal tube defects? Neuronal tube defects, or NTDs, including spinal bifida and anencephaly, are devastating congenital malformations of the CNS. NTDs, or neural tube defects, arise from incomplete closure of the neural tube, which forms by the 28th day of gestation. The cells of the neural tube and neural crest undergo exuberant cell division and proliferation, requiring nucleotide bases for DNA replication and cell division. Because folate coenzyme species are intimately involved in the formation of purines and conversion of DUMP to DTMP, folate deficiency can have a profound negative impact on neurulation. One important study of women with a history of delivering a child with NTD showed that, or neural tube defects, showed that peri-conceptional folate supplements of 4,000 micrograms per day reduce NTD occurrence by 72%. Later studies showed 400 to 800 micrograms per day in the peri-conceptional period are very effective in reducing the incidence of first-time neural tube defects. It is important to note that a well-balanced diet cannot supply adequate folate to exert this protective effect. Treatment of vitamin deficiency. Many authorities recommend replenishing cobalamin stores by IM injection, the administration of 2 milligrams of cobalamin daily by mouth. For patients who cannot absorb cobalamin, once-a-month injections are efficacious. With the first dose of cobalamin, megaloblastic hematopoiesis resolves by 48 hours and reticulites peak by 5 to 8 days. Oral route, 1 to 2 milligrams per day, will replenish folate stores and is effective even in the face of malabsorption of food-borne folate. Now we will move on to discuss aplastic anemia. Aplastic anemia, or AA, is a potentially life-threatening syndrome that results from failure of the bone marrow to produce cells of the erythroid, myeloid, and megakaryocytic lineages. This results in a dramatic decrease in red cells, granulocytes, monocytes, and platelets, otherwise known as pancytopenia. In general, the neutrophil count is greater than 1,500 micrograms per liter, and the platelet count is less than 50,000 microliters per microliter. The hemoglobin is less than 10 grams per deciliter, and the absolute reticulocyte count is less than 40,000 per microliter. A bone marrow examination is necessary to establish the diagnosis of aplastic anemia and reveals a hypocellular marrow without malignant or abnormal cells. Most cases of AA are acquired rather than inherited, and there is now abundant evidence that the suppression of hematopoiesis is immunologically mediated, with cytotoxic T cells playing the major role by suppressing early CD34 plus hematopoietic multipotential progenitor cells. Other less common causes of aplastic anemia include radiation, toxic chemicals or drug exposure, and viral injections. Regarding the epidemiology of aplastic anemia, in the Western world, the incidence of AA is approximately 2 per million individuals, but in the Far East, this incidence is 4 to 7 per million. This difference has been attributed to industrial benzene exposure, impure water, and genetic predisposition. The age distribution is bimodal, with peaks at 15 to 25 and 60 to 65 years. Etiology and pathogenesis. It is estimated that in approximately 10% of patients with AA, aplastic anemia, there is an inherited defect, often in DNA repair, vita infra. But the vast majority of defects are acquired with the number of CD34 plus multipotential hematopoietic progenitors and their progeny markedly reduced. In the past, a direct toxic effect or a defect in the stromal microenvironment were considered as possible causes of AA, but there is now abundant evidence that most cases of acquired AA are caused by cytotoxic T cell suppression of early CD34 progenitors and stem cells. Cytotoxic T cells are driven spontaneously by a growth factor-induced increase in mononuclear cell production of interferon gamma, tissue necrosis factor alpha, interleukin-2, to cause the CD34 cells to undergo apoptosis. There is good evidence that the FAS-dependent programmed cell death pathway is the major route to the demise of the CD34 cells. In this scenario, antigen-presenting cells present antigen, most likely autoantigens, so T lymphocytes and the T cells proliferate. The cytokines, interferon gamma and TNF-alpha, cause T cell FAS receptors to become amplified. Interleukin-2 causes polyclonal expansion of T cells. The success of immunosuppression therapies confirms the central role of immune-mediated cell destruction. We will now discuss drug-induced aplastic anemia. Chloramphenicol has long been known to cause idiosyncratic aplastic anemia with an incidence of 1 in 20,000. Recall that the general incidence of aplastic anemia is 2 per million, thus representing a dramatic increase in risk. It is also known that high doses of chloramphenicol can cause dose-related myelosuppression. This effect on the marrow abates with discontinuation of the drug. Unfortunately, the idiosyncratic form does not resolve when the drug is stopped. Antineoplastic drugs are associated with myelosuppression, but this effect will resolve when the drugs are discontinued. Further, growth factors can mollify some of the adverse effects of these drugs.